Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Welcome back to Medscape's Hear From Her podcast. I'm Christy Rohani Montes, Director of Clinical Strategy from Medscape. And today's discussion is going to be really interesting because we have two women leaders who are passionate about supporting women with chronic conditions through their childbearing years. Marie Teil is here. Marie is the global head of the Women of Childbearing Age Program at UCB. And we also have Cathy Nelson-Piercy, Professor of Obstetric Medicine at Guy's and St. Thomas's NHS Foundation Trust. So welcome to both of you.
Hi.
Hi, thank you, Christy.
So I wanted to start by asking each of you to tell us a little bit about yourself and your background, what has led you to become a leader in advocating for women with chronic diseases in their childbearing years. Let's start with you, Marie.
Sure. Thank you for having me. So I've worked for pharma for more than 20 years, but I started my career in academia, and I worked there in research, in ethics. I then moved to pharma, to the role that I currently have now, or a different, slightly lighter version of the role that I have now. So during my academic years, actually, I was working in clinical research, and I met many women living with chronic diseases. And some of them were thinking of having a family and starting to have children. And at that time, I witnessed the struggle to get information about not only the impact of their disease on their pregnancy, but also their questions about managing their disease, about whether they should stop or continue their treatment. And this is really where I realized the huge data gap that existed. Because I realized that these women and their doctors simply didn't have any information to allow them to make decisions that were grounded in science. So about 10 years ago, UCB approached me with the idea to better understand how to provide information and improve research for women living with chronic diseases. And for me, it was an easy decision. It was a no-brainer. It was a great opportunity to use my experience in clinical trials and in ethics to try to help these women who were of childbearing age. And this is when we established the program. And so this is a very personal topic and area for me, and as a physician, as a woman, and as a mother, really supporting this cause here.
Amazing. Thank you. How about you, Cathy?
Oh, thank you for having me. So I am a physician. I'm what is known as an internist. So a lot of people think that I'm an OBGYN because the title is obstetric physician, but I'm not. I'm a general internist. My background was actually in endocrinology, which I don't do now. But as a medical registrar, like a resident, I would be called to see women with acute medical problems, and I would be scared. I was scared. I thought, like, what do I do? This woman's pregnant. I don't know what to do. So I was struck by my own ignorance and my own fear. And then I realized that my bosses had the same reaction. And I realized that there was a total disconnect between obstetricians and physicians, internists. And then I was very fortunate enough to meet an obstetric physician who agreed to train me. And I realized that this was a gaping hole of practice, that women with not only chronic medical conditions, but also acute medical conditions in pregnancy got a raw deal because neither the internists nor the obstetricians necessarily knew what to do. And so the more I got into it, the more I realized, like Marie realized, that the reason they don't know what to do is because there's a big evidence gap and a big data gap. And we are often left as the doctors looking after these women, having to advise them without the amount of evidence that exists for the non-pregnant woman. And so it's the specialty of obstetric medicine is wonderfully challenging because you, on the one hand, deal with common medical conditions, but in pregnancy, and on the other hand, you deal with rare things that only affect pregnant women. So I've spent most of my consultant career looking after women with rheumatological diseases, neurological diseases, cardiological diseases. So it's a really I'm a general physician. The only difference is that all my patients are either pregnant, have just been pregnant, or want to be pregnant.
Great, thank you. So I mean, it is. It's a big hole. There's a big gap there, and just to kind of get a sense of it, how big is this issue of managing these chronic diseases in women who want to start a family or who are pregnant?
Yeah. So it's a big problem. It's always been a problem, but it is now bigger. So women now enter pregnancy older. They have therefore had longer to acquire chronic medical conditions. Women are now much more likely to have high blood pressure. They're much more likely to have diabetes. But they're much more, the older you are, the more likely you are to have developed a medical condition. So now, in the US, for example, 1 in 5 pregnant women will enter pregnancy with a chronic medical condition. Up to 70% of women will be taking medications for that chronic medical condition. And yet, a lot of people don't know the data about those medications that they're taking and the safety and efficacy in pregnancy. So it's an unmet need that is growing bigger because of the demographics that are changing, and women delaying having their children until they're older. And also the obesity epidemic is changing the women that we look after.
So, in fact, it's a huge problem because historically we haven't been doing research on pregnant women. So, typically, when you have a drug approved on the market, there have been a lot of study, a lot of data that have been accumulated, looked at, analyzed, and so that the company, the FDA, the scientific societies can say, okay, we want to use it. This is a drug that can help my patients. But typically in research, we exclude pregnant and lactating individuals. Huh? So we're talking a lot about pregnancy, but the same, you can think the same for breastfeeding and lactation. So basically, you end up with drugs that have absolutely no information to inform exactly what Cathy is saying. This decision, what do I do when my patient is pregnant and may need to continue her treatment? What is the best choice for me? And I think a lot of it for pharma is coming from fear. They've been, first of all, in the regulations, a lot of barriers not to do it. Huh? You may remember that pregnant women were considered as vulnerable. So, which is, I think, interesting terminology. Not anymore in the US, the terminology has changed, but that means there were a lot of barriers to actually conduct clinical trials in pregnant women. So, one of them for us has been liability. What does that mean for a pharmaceutical company to enroll a pregnant woman in a study? What does that mean in terms of the consequences of the impact of the drug? There are a lot of things happening, and the National Academies of Sciences in the US have been publishing a wonderful report on liability and clinical trials for pregnant and lactating women. And I think it's going to be really helpful for the community and for us to start doing more research and generating more data. But this is one of the big barriers that we've had. And we hear very often it's not ethical to do research in pregnant women. And all that, I think, is something that we need to change. It's a perceived liability. You can wonder whether it's ethical for a physician not to have data to give to a patient and to have this discussion with a patient at the time where she needs potentially this treatment.
If I could just add to that, Christy, the clinician is faced with a real dilemma. And the default position for many physicians is, I don't know if this is safe, so I'm going to stop it, or I'm going to advise the woman not to take it. And what it's important to understand is that for women with chronic medical disease, you only have a healthy baby if you have a healthy mother. And the default position by stopping, omitting, or failing to initiate a treatment in pregnancy results in that chronic medical disease not being optimally controlled. And that will usually result in harm to the mother and indirect harm to her unborn baby and her newborn child. Because if you take the example of rheumatoid arthritis, for example, epilepsy is another example. If you stop the drug and the disease flares or is not well controlled, then the woman is more likely to deliver preterm. She's more likely to have a small baby. She's more likely to develop preeclampsia. But the perspective of the mother is not thought about. It's not at the forefront of the clinician's mind. The people are obsessed with the harm to the fetus. And as I'm a mother as well. I remember having a minor medical condition in pregnancy. And I ran and asked my boss, can I take this? Even I, as a doctor who was in the field, was unsure and not confident to take a medication in pregnancy. So women require lots of reassurance, and that reassurance is easier to give with data. But it's really important that your listeners understand that the default of stopping is actually harmful in many, many conditions, or not starting.
I think for many years, Cathy, we've looked, as you said, we haven't done a true benefit risk for these women. We have looked at the risk that has always been, that we are focused on the risk of the baby, but we are not focused on the potential risk and benefit for the mother. And I think, and sometimes what we miss is actually this, the benefit for the mother could also be a benefit for the child, as you mentioned. And this is why I think ethically we've looked at it in a very conservative way. And now we need to change that. And we often say we need to protect women through research, not from research. And it's becoming an ethical matter. If you think about it, there are no other patient population, maybe pediatric aside, but we have now more data in pediatric as well, where we treat patients without data. This is unbelievable, but we're still in this situation today. So we really need to change this paradigm. And I think it's important that we all look at it and we all work on it together. It's truly a collaborative effort. It's not like pharma should do it alone, you should do it alone, the scientific societies. We all need to be able all together to make it happen. And so that's really the basis for empowerment of these women, empowerment based on data.
Absolutely. There's this assumption that women who are pregnant don't want to take part in a clinical trial. And I know, Cathy, you've had some experience with how to speak to patients and in fact, understand that and enable.
Yeah, I mean, I've been PI for many studies looking at medications in pregnancy and other issues in pregnancy. And my experience is, well, the first thing to say is that if you work in an environment, I think the environment is really important. If you work in an environment where research is expected, so women, it's the default that you will be asked to be recruited into clinical trials. If you think of how cardiologists operate, like, how do they recruit these thousands of patients? Because every patient that walks through the door or doesn't walk, is rolled through the door, gets recruited into a study. That's how the cardiologists can do these massive trials. That needs to be the starting point, the environment, the support, the research nurses, the funding has to be there to create this research environment. That's really important. But in terms of talking to women, my experience is that women are as frustrated by the absence of evidence as the clinicians are. They say, well, look, this drug is really good for me. Why don't we have data about this drug in pregnancy? So that if you then follow up with, well, actually, we are giving women this drug, but we want to research the outcomes on the baby and the outcomes on the mother. Obviously, that would be an observational study, but women are very, very happy to join those sorts of studies where they want to take the drug or they're not sure, and the clinician is in equipoise. In my experience, women, it's not as difficult to recruit women to clinical trials when they understand the benefit of gaining information. And the way I talk to women is coming into this study won't necessarily help you, but being in this study will help women like you in the future. And that altruistic vein is present in all of us. They can see the good. And for that reason, they will often agree to come into studies. Many are actually, as Marie says, empowered, and they say, well, yes, but I want to know the results. They want a guarantee of the feedback loop that they're going to individually be told the results, which as researchers we are duty bound to do and disseminate. And, when you break the code, there's no reason why women can't be told the results. So my experience is I quite privileged because I work in the teaching hospital, which has a very strong research bias within the Department of Obstetrics, but women aren't shocked when they're asked to come into studies, and everyone around expects it. So it's the sort of default position, which helps a lot. I accept that it is not that easy in different environments.
And it's so true. Women are you have this altruistic character that makes it, that gives them this opportunity to actually, you know, participate in these clinical trials and get that together, get the evidence together. So
I think this is wonderful. And of course, as you said, you're privileged, you're in a teaching hospital. That's what you've done all your life. You've been very, very committed to that. And I guess the more you do it, as all of what we do, the more comfortable you are doing it. But um, typically, physicians are not trained to doing that. And you explain your curriculum and how you got into it. So how can we change that? Because there's really they need to be physicians need to be trained about it, but there also need to be a changing mindset, a changing this approach, this risk adverse approach that you mentioned, that we all mentioned. So how I think this is that also a problem, right? Are physicians trained enough to do that in general?
It's a really good question, Marie. And I think COVID really helped here. The pandemic really helped because if you remember the recovery trial, we in our hospital, you cannot recruit to studies unless you've done something called GCP training, good clinical practice. You have to be trained in how to recruit women to research and to understand research governance. And that's a bit laborious. They fast tracked that training so that every clinician who met a patient with COVID could recruit to the recovery study. And as a sidebar, you will remember that, surprisingly, pregnant women were very quickly not made exempt from that study so that we could gain all the information about the therapies for COVID in pregnancy as well as the non-pregnant patients. And it was a beautiful exemplar of how to break down barriers, actually. Sadly, the vaccines story was different, and that we now have a lot of vaccine hesitancy because those setting up the vaccine studies didn't go with that originally. But those doing the recovery trial said straight away, we are not going to exclude pregnant women. Pregnant women are more susceptible to COVID. They're more likely to die. We're not excluding them from these studies. But you could have different arms. And as the researcher, you could say, well, I'm happy with that drug, that drug, that drug, because of the biological plausibility that it's not going to harm, but I'm not happy to recruit to that arm. So the clinicians were left with some autonomy, but they broke down the barriers of that training, Marie. And that training is a bit laborious. For clinicians that don't have an academic role, it's not just, you can't just start recruiting to clinical trials. You have to be trained to do it. And like anything in life, the more you do it, the easier it is. And that's why the experience is concentrated in academic centers. But I think I don't have a problem with that, provided the results are cascaded to the other centers. I don't think otherwise you have inequitable care, which obviously is not right.
great, thank you. And what about initiatives? Sort of moving on to what are the initiatives that either of you can tell us about that are addressing these issues? Marie.
So first of all, I want to say it's very encouraging because we see more and more initiatives, and we see a true change over the last, I would say, 7, 8 years. We've seen a lot of changes in the environment. One of them in the US was the PRAGLAC task force that was mandated by Congress. And we had the recommendations. Now there's a paper about implementation, how to implement the recommendations. So we really have at that level a collaboration and people trying really to make a change. And more recently, or it started last year, the implementation of the ICH guidelines, which are harmonized global guidelines. So this is, again, a group of people from all over the world. And you have regulators from all regions. You have physicians, you have scientists, you have pharma, you have policymakers, and everybody's getting together. And they're currently working to guide on inclusion of pregnant and lactating women in clinical trials. So we will have guidelines. We will have a way to go that is really, this is a global one. So it's not a country or another. In Europe, we've seen the conception IMI group that has been also very active in how do we give more data. It's a fantastic partnership between the Innovative Medicine group and pharma, more than 40 companies that are part of it, really trying to work together and to provide the best way to give information to patients. So it's very encouraging. There are a lot of groups. It's almost flourishing depending on the countries, but it's because people recognize that they cannot do it alone. This is not a physician, a researcher. It's not about Cathy, as great as your place is, Cathy, doing it alone. This is not us as a small company trying to do it. It's actually all together, talking to regulators, collaborating together, that all the stakeholders that can make it happen. And I see a lot of that happening. So it's only encouraging. And Cathy, I'm sure you have other examples of initiatives.
So Marie and I are both involved in a fantastic initiative called Bridge, which stands for Better Research, Information and Data Generation for Empowerment. And it's independent. So that's really important. And the other really important thing about Bridge is one of the co-chairs is a patient with lived experience of a chronic medical condition in pregnancy. And this group is really unique in that it's developed a report and it's totally committed to sort of action orientated outcomes to overcome these information gaps that we were talking about, to change the mindset of not just pharma, but the women, the clinicians. And it's not limited to any one chronic medical condition. So this is the other, historically, people would concentrate on one condition. This group deals with lots of different chronic medical conditions. And Marie's spoken a little bit about the philosophy, but the report goes through this changing paradigm from blockages and barriers to the fact that actually it's unethical not to do research in pregnant women. If we're going to change the landscape and get the data, we have to make it the default to include them. And this is a really important concept. And I think the Bridge collaboration and the report is part of this sea change that Marie's referred to. This is a gradual process. It evolves. I'm the most impatient person in the world, and I want everything to change overnight. But I realize as I get older that it doesn't change overnight. It has to be embedded in the way people think. And not everyone thinks about this the way Marie and I have discussed. So we've both become more patient, haven't we, Marie, over the years?
Definitely. So, Marie, can you give us an example of how this landscape has changed?
So something we can think about is something that happened almost 10 years ago, which is the pregnancy and lactation labeling rule in the US. And that was led by the FDA. And basically what the FDA did is changing the way the classification in the pregnancy label for all of the drugs. And we went from a system that was very rigid, where you had letters most often, as Cathy mentioned, based on very little data, because there were very little data, a lot on fear, to now package inserts and informations and label where we really have more information, or at least the FDA is asking us to put more information. So this is a trend, and this is a practical thing that they basically said, we remove these letters and you need to give data. You need to give evidence. You need to generate evidence for your drugs. So we see this change that is becoming, of course, as Cathy mentioned, it's not happening overnight. It takes time to generate this data, but we see this trend happening and this ask for more information in the drug labeling. And I think ultimately this is what is going to help also in the discussion of Cathy with her patients.
And I think that's right. The EMA and the MHRA, so the European and the British regulators, now have consortia and they meet with clinicians, they have groups, and basically they're listening, is my impression. They're listening, they want to hear the perspective of the clinicians and the fact that, the exclusion and the warnings for pregnancy and lactation is that they're changing their attitude in terms of how important it is to look at the real world evidence, look at the post-marketing surveillance data, and incorporate that. It be more responsive to the clinicians. So I think not just the FDA, but also the EMA and the MHRA, they are evolving their perspective really by beginning to listen to the women themselves and the clinicians. I think that's probably summarizes the changes that are happening, the changing landscape, Christy.
Thank you. And finally, can I ask both of you for your final thoughts, words of advice for women, physicians, healthcare leaders, women patients, and men too?
Yeah, so we mustn't forget the men. So if I think about the perspective of the clinician having to advise women and their partners about having children, I do a lot of pre-pregnancy counseling. What I would say to other clinicians is listen to the woman, listen to her concerns, validate those concerns, don't dismiss them, don't patronize women, and don't assume that women want to be told what to do or they want to know whether something's safe or not safe. We never say something's safe. We talk about the evidence and we use something called shared decision making with the woman herself. So my one-liner is basically listen to the woman's concerns, validate her concerns, and make her part of your decision making.
Thank you. Marie?
And perhaps for the women and their partner, it's really about being proactive. Ask your physicians. Be your own advocate. Make sure you communicate to your physician as early as possible your family planning wish. And I think because this discussion, this shared decision making that Cathy is talking about is important, you have a big piece on it. You have a big part of it. You shouldn't let it happen and come passively to it. You have to be proactive in your disease management during this period and initiate this discussion if your physician doesn't do it. Not all physicians will do it. So it's important for you to be active in this involvement because this is pretty much what's going to lead to a better outcome for you, for your family, and for the child to come.
I just want to add one more thing, Christy. If your physician doesn't know the answer, ask to be referred to somebody who might. That's the other. The woman has to feel truly empowered to seek out the information. And that might involve seeing a different physician.
Absolutely. Great advice. Thank you both. Thank you for joining us. And we look forward to welcoming you again to our next episode in the Hear From Her series.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.